The SA node is a bunch of these round cells. They're called P cells, also known as pacemaker cells, which are connected via gap junctions to the cardiac muscle, these long cardiac muscles. I think I drew one over here. Yeah, here we go. So these round cells over here are your pacemaker cells. So I'm going to draw them as green over here. See, these green cells are your pacemaker cells, or P cells in the SA node. So if you look at your heart over here, this is your heart. You have an SA node in the right atrium, somewhere near where the vena cava is going to take insertion into the right atrium. So somewhere around 1 centimeter around this area, you have this SA node, and this SA node is able to excite itself. Again, I'll tell you how it happens later. Somehow it's able to excite itself and cause an action potential to form over there. Now this action potential is meaning there is depolarization taking place over here. So because of this depolarization taking place in the pacemaker cells, and they are connected via gap junctions to the cardiac muscle, you are going to have this wave of depolarization from the pacemaker cells to continue because of syncytium. Syncytium. Syncytium is, they're all together, like sentient. These beings are sentient. You might have seen it in those alien sci-fi horror stories. Oh, that thing has become sentient, meaning it's self-aware, or sometimes, it's like all of them are synchronized in their thinking. Well, here the pacemaker cells are synchronized with the cytoplasm of the cardiac muscle, which I've drawn over here as branched. Can you see these red tissues over here? These are all branched cardiac muscles. Okay, so what happens is the depolarization here causes depolarization in the cardiac muscle, and this depolarization initiates your phase 0, also known as spike potential, or that's where the main depolarization happens. This is called phase 0. This is what the ECG picks up for depolarization waves. So remember your ECG. We'll have a class on that very soon. ECG has its own wave of depolarization and repolarization it will pick up. So atrial depolarization is called the P wave, if we remember. There is the P wave, then there is the PQ segment, QRS complex, and T wave. P wave, Q is this negative wave down going here, R is the positive wave, S is again a negative wave that is going down here, and then you have the T wave over here. So this P wave is due to atrial depolarization. This QRS complex is due to ventricular depolarization. So when we say that this is the P wave, that means the atria is undergoing phase 0 that time. And QRS complex, when you see this, that means the ventricle, its different parts are undergoing depolarization at that time. If we look at lead 2 of the ECG, Q wave represents septal depolarization, R wave represents anterior wall depolarization, and S wave represents the posterior wall, the base of the heart depolarization. Okay. But for repolarization, we have the ventricular repolarization wave, that is represented by phase 3 of the ECG. Okay, phase 3 of the cardiac action potential, which is your delayed final repolarization. Okay, delayed or final repolarization. Because your ECG is a galvanometer, it only picks up big changes in the potential. Okay, if there is no change, it gives a straight line, a horizontal line. It does not give you a deflection or a wave. So if you want to see waves, it's look at the ECG like it's a galvanometer. An ECG is a galvanometer. It picks up rate of change of voltage per unit time. It's like your car having an accelerometer. The accelerometer does not move when the car is moving at a constant speed, but when you change the speed of the car, like you're braking or accelerating, you're pressing on the pedal, then you will see a change in the accelerometer taking place. Anyway, so we have phase 0, which is your spike over here. This is due to sodium influx. And then you have your phase 1, which is early repolarization. There's a partial repolarization taking place because the sodium channels have closed and potassium is leaving. I'm going to talk about this in more detail. I'm just priming your brain to it right now. So you have early repolarization or potassium efflux. Then after that you have the plateau phase. So the potassium is leaving the cell, but eventually there's another channel that opens up, and that's the calcium channel. These calcium channels, L-type calcium channels, they open up, calcium comes in, and it balances the potassium leaving. So these cations are coming in, and they're balanced by the cations leaving the cell. So you get this kind of a balance taking place. This is your plateau. Then you have phase 3, which is potassium efflux, again continuing, and calcium influx has stopped over here. So this gives you delayed final repolarization, and finally the RMP is obtained over here. Now look at this. This is action potential which lasts a very long time. If we look at this duration, it is up to 300 milliseconds. 350 milliseconds for this entire action potential to take place. So if we see this action potential is really long. And you remember the concept of absolute refractory period and relative refractory period. That's again very important over here. So absolute refractory period is when you give a stimulus to a muscle and or to an excitable tissue, and it does not give you an action potential. Absolute refractory period is when no matter how strong the stimulus is, you will never get an action potential. And that absolute refractory period starts with phase 0, meaning the initiation of the spike potential, up to the 1/3 of final repolarization. So this is absolute refractory period, where you don't get too much action potential. Relative refractory period happens after this, after this 1/3 of repolarization, up to the restoration of RMP. So that means most throughout the entire action potential duration itself, there is refractory period. Relative means you need a stronger than normal stimulus to initiate an action potential over here. So because of the entire duration of your action potential being under some form of refractory period, whether absolute or relative, that means your cardiac muscle is non-tetanizable. Non-tetanizable. What does that mean? Remember tetanizing current in just watch the excitation contraction videos, and you will know that your muscles, your skeletal muscle, if you look at them, like if you hold a pen or if you're holding a cup of water, you are giving a sustained contraction to your muscles to maintain that position. So to maintain a particular position, there must be a sustained contraction, and that requires a rapid chain of action potentials in quick succession. So you have action potentials running down the neurons and down the muscle in quick succession over there. Now this is where it gets tricky. If we had tetanizing currents in the heart, things can go very bad, because you want your heart to pump and then to relax, fill up with more blood, and then pump again. And if you have a tetanizing current, if the heart gets tetanized, and it's not that it's your heart is not tetanizable completely, there are chances for it to get tetanized, but if it was easy for your heart to get tetanized, many of us would not live, because the heart would stay in a sustained state of contraction. It will not fill up with more blood, it will not relax, undergo diastole and fill up, and then people die. So that's how some dangerous arrhythmias take place, especially with problems with potassium levels. Remember, when you mess with potassium levels, your heart gets affected. When you mess with sodium levels, your brain, your CNS gets affected. So potassium levels affect the heart. As you could see, potassium plays an important role in many parts of the heart over here. Phase 1, phase 2, phase 3. Okay, so let's just talk about these phases in a more organized manner and a more neat manner. I'll just clear these out over here. Okay. The first stage we'll talk about is phase 0. So first of all, there was RMP, resting membrane potential, that's phase 4, and the RMP of this cardiac muscle was minus 90 millivolts. And this minus 90 millivolts is because there was a sodium potassium ATPase pump, which is maintaining that ionic concentration and getting rid of excess sodium which got into the heart. during action potential. And at the same time, there's this sodium calcium exchanger that gets rid of calcium from the cytoplasm of the heart. Now what happens is you have the SA node giving it with the P cells, the pacemaker cells, undergoing action potential, and that is going to induce cardiac action potential in the skeletal muscle. So the pacemaker cells make this action potential, and because of gap junctions, this depolarization that takes place over here is going to spread and activate the cardiac muscle and make this kind of action potential, which we know. So that gives you phase 0. Phase 0, you get this phase 0, which is your spike potential. You could see phase 0 over here. I'll highlight in red. This is phase 0. This is where you open these channels called your voltage gated sodium channels, like the ones you studied in the action potential in neuron, same ones. So these are fast voltage gated sodium channels. They open up, and if you look at them, they have two gates. One is the M gate, which faces the ECF, and one is the H gate. And again, watch the video on action potential, and it'll help you understand what's going on. So what happens is, this is the state of the of the sodium channel in resting state. And if you look, sodium is 140 milliequivalents per liter on the outside, and sodium level in the cell is 14. So what happens is, when you depolarize the cell, with the pacemaker currents over there, you get this depolarization spreading over here via the gap junctions from the pacemaker cells. It will cause the cell to become more positive, this cardiac muscle to become more positive. So what's going to happen now? The M gate opens up and the H gate starts to close, and while this is happening, more sodium can gush into the cell, because there's 140 milliequivalents of sodium outside and only 14 on the inside. So along the concentration gradient, the sodium can quickly gush into the cytoplasm of the cardiac muscle. So this is the same mechanism which you have seen in your this one, neurons action potential. Watch that again. I'm emphasizing, you have to start with the basics, then only you can move on to the next chapter. That's how physiology is. If you skip a chapter in physio, it's like skipping 1 or 2 classes in mathematics. You won't understand how you derive an equation, if you miss 2-3 steps. So that's the same thing. So please watch that video again. And now, so these sodium channels, if we look at them, they are rapidly activated within 0.1 milliseconds, and they stay open for around 1 to 2 milliseconds, just like in the neuron. And if we see these sodium channels, they cause the spike potential to develop. So from minus 90 millivolts RMP, you are now going to reach plus 35 millivolts over here. Now, here we have the sodium channels. They get blocked by class 1 antiarrhythmics. They get blocked by class 1 antiarrhythmics over here. Okay, so there are some drugs which prevent arrhythmias, dangerous arrhythmias from happening, and we call them class 1 antiarrhythmics, like quinidine or lidocaine, procainamide, and all these things you'll learn about in pharmacology when we go there. Just understand that these drugs block the sodium channels, and they will slow down the they slur the spike, they reduce the slope of phase 0. You could see how this is almost like 90 degrees, this phase 0 over here. It's vertical. If you give a sodium channel blocker, you are going to reduce the slope of phase 0 and reduce its amplitude also a little bit. So what happens now is, you could see that if this in red was the original action potential in this muscle. Now what happens is, when I give a sodium channel blocker, it is going to reduce the slope over here and prolong this action potential a little bit, and this is supposed to increase the duration of the absolute refractory period. So this, look at the difference. This was the duration of absolute refractory period. Above here is one normal muscle's action potential. This is the absolute refractory period duration, you could see in normal muscle. When I give sodium channel blocker, it slurs this slope, it reduces this slope. You could see from this red vertical line, we have now got a slurred line, so it will slow down your action potential, and that is going to stretch your absolute refractory period just a little more, so it gets prolonged even more. So you cannot get another tetanizing current initiated over here, another action potential, because, and how you get arrhythmias, one of the ways is you have some bad tissue that fires and gives a shock or a current to the surrounding tissue when that tissue is somewhere in the relative refractory state. So that gives you a dangerous arrhythmia that causes you to eventually go into cardiac arrest.